morning, everyone. First of all, I just wanted to thank the organizers for giving me the opportunity to kind of share with you my perspective with regards to motor neuron disease. This is certainly, a topic that many of us are very passionate about. Certainly at UMMC in particular, and also been able to share this with our colleagues around Malaysia and also around the region, as is evident by Sheila being here today as well. So if I could just, share with you. Okay, so I'm going to talk to you today about motor neuron disease, and this is really going to be targeted for those of you who are at different levels. So I'm not going to make it too kind of like complicated. There will be some slides that would appear a little bit complicated, but I'll try and simplify it as much as possible. And basically what we're going to do today is go through what we know of what MND is, how one diagnoses, what the epidemiology is, and what the management is, and also to share with you some local perspective based on our own experience here in Malaysia. Okay. Right. Okay, so in terms of terminology, so you would hear motor neuron disease also being referred to as MND, which is what we call it here, but it's also been referred to as ALS, amyotrophic lateral sclerosis, and that is really something that the Americans tend to refer to MND as ALS, and in America as well, it's referred to as Lou Gehrig's disease, and also particularly for the healthcare professionals, particularly students and those who are going for exams, we sometimes, to be sensitive, we would refer to it as anterior horn cell, just really because of the connotations that's associated with MND. So what happens in motor neuron disease? So basically what is going on is that you get progressive degeneration of the voluntary motor system. So we're talking about the spinal anterior horn cells. We're talking about the certain motor cranial nerve nucleus. We're talking about your corticospinal tracts. So those are the tracts that are coming from the brain, going through the spine, that goes to the muscles. The corticobulbar tracts. So those are the tracts that connects the centers that tells your, your speech and your swallowing muscles to talk. So those are the tracts and the nuclei that are involved. And degeneration of this motor system causes you to eventually get muscle weakness. The eyes and the sphincters do not tend to be as involved, and certainly not in the early stages, with very, very few exceptions. And I will be talking about it later. And now we do recognize that it is not just a disease of the peripheries, it's actually a disease also of the brain, because there are patients, when you do proper testing of their cognitive function and also the behavior, there is some involvement and some impairment. It could be very, very subtle, but there is some impairment in almost 60% of patients. So just to kind of like cement what I had just said before. So what I'm talking about in terms of cortical spinal tracts, so that's your cortical spinal tracts going through here, corticobulbar tracts, and also these are the ones that are going to, these are the bulbar muscles, your muscles for speech and swallowing, and the green ones are the peripheral nerves, because once they go down through the spinal cord, they then start to innervate the limb muscles. So an overview. So this is what I meant by, a very complicated slide. So overview of the pathogenesis. So I think it's important to just understand what is actually going on. Why is it that when the patient gets degeneration, what is the process that leads to this degeneration? And you will see here this very complicated kind of diagram. And basically, this is your peripheral nerve. So this is the nerve, the motor nerves. And here you've got the inner bit is the axon. This is the myelin, which is the sheath. So when you look in greater detail is what is happening at the cellular level. And just to put it simply, so there are so many different factors that contributes towards this degeneration. And this is one of the reasons why it is not so straightforward to actually treat patients, because there are so many factors. So if you focus on one thing and you're not focusing on the rest, then the degeneration will probably continue. So the axons can be involved. So you can get axon breakdown. This is the glia. So these are the supporting cells of the nerve. So when there's dysfunction of that can also contribute to this. Free radicals and oxidative stress. So these are like the byproducts. And then you can get the mitochondria, which is like the batteries within the cells. So these can become faulty. You can get impairment of the messaging system of the genes between the repair of the DNA and also the messaging system within the DNA actually produce. Part of that is your RNA. And then you've also got transport failure. So you've got dysregulated, the vesicles that are being transported can be affected, and also the transport within the cell and the nucleus. And you can then, that all can lead to protein aggregation. So that deposits and also cause problems there. And then there are nutrients for the nerve that can also be insufficient, that contributes to this. And then you have hyperexcitability. So when you have too much of an excitability chemical, like glutamate, for instance, so that also can cause the nerve to degenerate. So all of this together are some of the pathophysiology that we think is contributing towards the motor nerve being degenerated. So I'm just going to talk about the burden. So this is based on a study done by the Global Burden of Disease 2019, and specifically on motor neuron disease. So you can find the publication in Lancet Neurology. And if you look at this, okay, so those areas that are red and orange represents areas where MND is thought to be very prevalent, so a higher frequency of it. And those in the blue are where it is thought to be not as frequent. So let's just highlight. So this is our region here, and we are thought to not be so prevalent. But when you look in further detail, I mean, this really are high-income countries to start with, and also the countries where the majority of research is really coming from here. So you've got proper epidemiology studies in this region. So therefore, this is actually quite deceptive because we don't have very good population studies here. And hence, it's not that we don't have a lot, more MND patients, it's just that we're not probably picking them up. Roughly, the epidemiology is about 2 per 100,000. And it's thought to have an average age of onset of about middle age, 60 years, for those who have a sporadic form. So this is versus those who have a familial form, which is something that's inherited. Men are thought to be more affected, although once the females reach menopausal age, that kind of like discrepancy does kind of level out. And this brings into consideration whether or not there might be some hormonal factors here. Ethnicity at this stage, geography, occupation are not thought to be linked to an increased risk. So the Malaysian experience, I just wanted to share with you, why I think that we are underestimating. So this is a study that has just been published towards the end of last year, and we were able to look at our cohort. So some of you may or may not know this, but UMMC, which is where myself, Professor Loh, who introduced us, we are based there, and we were able to actually set up a multidisciplinary clinic for MND, which at present is, I believe, the only one in Malaysia. So we do see quite a lot of patients, and we are seeing the patients certainly in the area. And what we found is that, compared to the high-income countries, so let's just concentrate on Germany here, and Portugal has got pretty good data as well. So we are seeing what looks like a lower incidence. Rather than 2 per 100,000, we're seeing 0.5. So, 25% less. But we believe that is likely an underestimation. And our ratio was slightly higher for the males. Our age of onset was quite similar to those in Germany, maybe slightly younger than some of the other, slightly older than some of the other Asian countries. And our diagnostic delay was slightly higher as well, at about a year. But what we did find is that when we look at patients with a definite diagnosis of MND, using the research classification, we are seeing at presentation 46% compared to 14% in Germany. So they are presenting to us when they have already got quite extensive disease. So that's one of the reasons why we think that it's likely a lot of these patients may not be presenting or may not be picked up. And the survival in terms of months was about 30 months, and that is actually similar to the Western cohorts. So that's just to give you a bit kind of overview of our local experience. So how do we diagnose MND? And I think this is, an important slide, especially for the healthcare professionals, because there is a fairly new diagnostic criteria. So we're moving away from the Ellis-Coriel criteria and Awaji criteria, although those are still very helpful. But the Scheffner, so this is now referred to the Gold Coast criteria because that's where they got together to do this. And essentially, you're using your clinical tools, okay? So what you need to identify is a patient who has progressive motor neuron impairment, and that is documented by taking a history or repeated clinical assessment. And the patient needs to be completely normal before they presented to you. So they had completely normal function prior to presenting to you. And from the history, it's as if, they had an onset of, a little bit of weakness, and then that progressed, and it progressed to the leg. So that sort of progression we're talking about. And on examination, you find that they have a mixture of what we consider an upper motor neuron lesion, as well as a low motor neuron dysfunction. And you need it in at least one same body region, okay? Or you can have two low motor neuron dysfunction in at least two body region, and other diseases must be excluded. So what do we mean by upper motor neuron? So we're talking about patients with increased deep tendon reflexes. So this includes some, patients that got wasting of the muscles, but when you do the reflexes, they're present and they're there without reinforcement. So that suggests to you that that's pathologically brisk. And when you do reflexes, they spread to the adjacent muscles. Or patients who've got the presence of pathological reflexes. So that includes the Hoffman sign. So that's when you flick the fingers, and that suggests that there is increased pathological reflexes in the cervical region. Babinski sign, that's when the plantars go up, cross adductor signs, and also a snout reflex. So those are all pathological reflexes. An increase in what we call velocity-dependent tone. So that's when you see that they have spasticity. And also they've got this slow, poor coordinated voluntary movement, which you cannot attribute to weakness of the lower motor neuron, or you could not attribute this to Parkinson or Parkinsonian type features. And this is really important because, you have to understand that, and I will be sharing it later, that there is some overlap with other neurodegenerative disease. And what do we mean by low motor neurons? So looking just with the eye on clinical examination, you can see wasting, you can see weakness on examination. Or if you don't see that with clinical examination, EMG abnormalities. So sometimes you see the muscles look okay because it depends on what the patient's premorbid muscle looks like. But when you do EMG, you find that they have evidence of chronic neurogenic changes, so something that's been going on for a while, and also ongoing denervation, so something that is happening continuously. And what does that look like? I'll be sharing that later. So clinical signs, so this is just just to highlight upper motor neuron signs. So upper motor neuron sign is basically something that's arising from your brain, your spinal cord. Low motor neuron signs are really those arising from your peripheral nerves. So the EMG findings I was talking about, basically it's findings that represent, so you've got a surviving motor unit here, and you've got a degenerated motor unit sitting next to it. So what is happening is that as this motor unit degenerates, the surviving motor unit is trying to help by innervating the degenerating motor unit. So what you see on EMG is that you see active denervation changes, which looks like positive shaft waves, which are here, and fibrillations, which looks like this, and chronic neurogenic changes, where you get these large amplitude and you get these polyphasic units, okay? So these are the pattern that you will see when you stick a needle in. So body regions, what do I mean by that? So we're talking about 4 body regions when we talk about MND in terms of the diagnostic criteria. So we're talking about the bulbar region, the cervical region, the thoracic region, and the lumbosacral region. So we're not necessarily talking about, upper limbs and lower limbs, because when you talk about the thoracic region, for instance, so this is one of the reasons why we do, with EMG, we might do thoracic paraspinals, because that represents the thoracic region. Cervical region, actually your upper limbs, most of it is actually arising from the cervical region. So the clinical phenotypes that we see, what are the clinical phenotypes? So there are 4 main types. This is in the main. So the classical, which is the classical limb onset, so you'll find that they will have concomitant corticospinal and anterior horn cell degeneration, i.e. a mixture of upper motor neuron and low motor neuron syndrome, okay? Progressive muscular atrophy, that tends to be more predominantly low motor neuron. Progressive bulbar palsy, that tends to be somebody that presents with progressive problems with swallowing and also with speech. Primary electrical sclerosis, that tends to be somebody that presents with more of upper motor neuron features. So typically 90% of patients, it happens without a family history. So by family history, we mean, the first relatives, there's nobody with a family history of any neurodegenerative disease, but rarely we do, there are patients, and it's quoted to be about 10%. In our cohort, there was maybe about 5% of patients that actually had a familial or had a genetic cause. And this is just to kind of illustrate what it might look like. So these are your classical type of MND. So you've got your spinal onset here, you've got your bulbar onset, and I've just highlighted here sort of what sort of percentages they are. And below here is what is thought to be, the prognosis for this group of patients. PMA, you would have predominantly low motor neuron features in the limbs. Primary electrical sclerosis, predominantly upper, lower, and if you stick a needle, you might find that there are low motor neuron features. And these are some rarer ones, including flail arm and flail leg syndrome. So classic ALS, which makes up about 70% of cases. So in about a third of those, they present with bulbar symptoms first, and about 2/3, they present with spinal onset, okay? So this is basically the sort of category. So you can either start in the spinal onset, in the upper or the lower limbs, and examination will find them having brisk jerks, spasticity, wasting of circulation for low motor neuron. And in the bulbar, they may have brisk jaw jerk, pseudobulbar effects. So that's when they might laugh inappropriately, cry inappropriately. Spasticity is upper motor neuron, and you might see tongue wasting of gesticulations. So this is just a brief overview of PMA, where it could be focal or patchy to begin with. And then as time goes by, you will see that it progresses to other regions. And eventually they do develop respiratory failure. So the survival is longer than the classical ALS. And towards the end, you will start seeing the upper motor neuron features becoming more prominent. PLS, so spasticity. So you will find that with PLS patient, and we have seen quite a number of these, when they present to you, they don't actually have weakness per se, What is disabling them is the marked spasticity. And this group of patients, you really want to be looking out for other causes of a predominantly upper motor neuron features. So typically they would need, for sure, an MRI of the brain and the spine, because you want to make sure that you're excluding things like demyelinating disorders. And once everything comes back as clear, or you might actually find hyperintensity, which supports a diagnosis of PLS, then the key thing here is to try and manage the spasticity. Okay, the average onset is a little bit younger. So this group of patients, you might find that they have some bladder and bowel symptoms, okay? And the life expectancy is better. Some patients can actually survive up to 20 years. Bulbar palsy, so they present with dysarthria. We do tend to see this in more females, tend to be older patients, and they also tend to get this frontal temporal impairment as well. And again, as I've said before, mixture of upper and lower motor neuron. Every so often, as a clinician, you might get a patient that presents to you with a dropped head syndrome. And to me, that always, two things you need to think about. Myasthenia gravis is one, and MND is the other. Obviously, make sure that you've excluded myasthenia gravis because that's a treatable condition. But when it does turn out to be MND, it's typically associated with some respiratory involvement, and they tend to do less well. Flail arm syndrome. So we have seen quite a number of our patients presenting with this, where they come in and it's really the arms are completely wasted and they're just walking around, they're talking to you, and the arm is wasted and completely weak. So much so that they have to swing the arms to be able to utilize it. And for some reason, this group of patients tend to be more male rather than female. So, you're already seeing that there are patterns there that suggest that there is likely to either be a genetic predisposition here or some hormones that might be also, playing a part in how these different patterns occur. So as I've said before, we now recognize, so for a very long time, we thought MND was a peripheral problem, an anterior horn cell problem. But then we started seeing that, actually these patients are having cognitive problems as well. So their behavior, their mood is being affected. And there's now certainly an overlap with frontal temporal dementia. And when you look into the spectrum further, and this is really, the pathophysiology that I talked about before. So one of those proteins that we're talking about is something called TDP43, and that is actually involved in a lot of other neurodegenerative diseases. And we do now see also, you've got FTD at one end and ALS at the other end, but actually we've also seen patients where it has overlapped with Parkinson's disease in the family. It's overlapped with schizophrenia. So those are things that when you take a history, you want to try and tease that out from the family history. It's not just a family history of MND. It's actually a family history of any degenerative disease. So this is quite a good overview. A little bit dated now, but it gives you some idea of those features that are associated with the longer survival and those with the shorter survival, genetic factors that contribute to that, environmental factors that contribute to short survival. So you've got here smoking and also low socioeconomic status. And of course, certain treatments that have been shown to improve survival and those that have actually been shown to make survival a little bit worse. So what I want to share with you now is this concept where, researchers have felt that ALS or MND or ALS is actually a little bit like cancer. You see, the person was born and they were completely normal. And somewhere in the adult stage of their life, something happens that causes them to develop this disease. So they started thinking about this multi-step process, which is something that, this concept was used in cancer patients. So we now recognize that, and there's pretty good evidence from Europe and also now in Australia, that it is a multi-step process. So when you have an actual genetic mutation, okay, so SOD1, C9orf72 or TRDBP, so that means that, you know, you have the mutation, so one more step and you develop MND. Okay, for C9orf, if you have the mutation, you do not always have to have the disease. It's when you have two other contributing factors. And with this, you have 4 contributing factors. And we're now talking about those without mutation, which represents 90% of our patients, okay? So there are several factors here that cumulatively causes you, you know, triggers something that causes the nerve to start to degenerate. So what are these factors? And this is actually quite an exciting area of research, because if we understand this, then hopefully we can understand how we target therapy. So these are all the potential genetic mutations that may predispose you. So some of this could be some variants. You know, so you've got these which are known gene mutations, but you could even have, you know, what we call genetic variants, SNPs. So you could have that, but that alone may not make you, you know, result in you developing MND. But when you throw in lots of other factors, and these are some of the environmental factors that could actually, you know, be added to those steps, and that then switches something on, it causes the nerve to degenerate. So this is really now how we think someone goes on to develop MND. So that's really MND. And, you know, it's so important that you exclude things that, you know, does not have a similar prognosis, okay? So some of the things that could mimic MND would be a spinal muscular atrophy. So the type 1 to type 3, those are childhood onset. So that is, you know, something that happens in childhood. So you probably won't miss that to what we're talking about here. But the adult onset can sometimes be a little bit tricky. But one of the key things is that they're slower to progress. There is probably some kind of family history. And then, of course, if you do the SMN, the survival motor neuron gene, you'll find a mutation there. And that's not something that you see in patients with MND, ALS, okay? And then in our cohort, you know, in Asian cohort in particular, there is this condition called monomilic amyotrophy, also referred to as Hirayama. So those patients can present, and it may, you know, you may start thinking, oh, could this be flail arm? But the presentation is actually fairly different in that the weakness is limited to certain myotomes, so C5 to T1, but particularly what you will see is wasting of the small muscles of the hands, and it can be asymmetrical, or it can just be one side. And you will see this kind of brachioradialis being spared, and then you get the scalloping because they get wasting of, you know, the flexor compartment. So this patient tends to present in the juvenile stage, so late adolescence and early 20s. They might progress over a few years and then they stop. Okay, so this group of patients tend to be, the prognosis is actually, they should have a normal kind of like lifespan, okay? So I'm just going to share with you a case example, just really for you to think about. And this is really more targeted to the neurologist especially. So 51-year-old man, you know, this guy had a normal childhood, school, played football, played badminton, but in the last 10 years when he presented to us, he noticed that he easily tires. Swallowing and breathing was okay, denies any sensory symptoms, and mainly finds it difficult to go upstairs and difficult to run. So when you go through the history, interestingly, his brother also has a similar condition. So you already know this is likely to be something that's inherited. And then his mom's sister also had a son with a similar problem. So when you see something where the boys are more affected and it's coming through the mother's side, okay, so you start thinking whether or not this is something that is to do with an X-link, okay? Because it's typically passed down by the females, and it's the boys that actually get the disease and the females tend to be protected. Okay, so this particular patient had facial myokymia, so that's like fasciculations of the facial muscles. The tongue was very atrophied. There was a little bit of hand tremor. And when you did the reflexes, they were not brisk, they were actually reduced. And when we did the nerve conduction studies, it shows that the sensory potentials are actually affected. And nerve conduction studies for motor neuron disease, that's typical, is that you don't get the sensory involved. So this is a condition called Kennedy's disease, and it's X-linked, and it's also called spinal bulbar muscular atrophy. It affects only males. And what's happening is that there's abnormal trinucleotide repeat in the androgen receptor on the X chromosome of the man. And it typically begins in the third and the fourth decade. They get limb girdle weakness and they get bulbar symptoms. So this is very, it looks very similar like our typical sporadic MND. So, but it's important to actually make this diagnosis because again, their lifespan is much better. And what the distinguishing features include will be this kind of like facial fasciculations. They can have gynecomastia because, there is some involvement of the androgen receptor there. They get hyporeflexia. They have this hand tremor because the sensory potentials are involved. They get tongue atrophy and they don't have the upper motor neuron features. So do bear this in mind when you do see patients. So investigations that we do to exclude. So we do an MRI brain and cervical cord, and this is mainly to make sure that you're not, missing the brainstem conditions or a cervical spine lesion, particularly a cervical cord compression. Sometimes that can actually cause, similar kind of like wasting in the hands, spasticity. But one of the key features of cervical cord disease is that you should not get anything in your cranial nerves. You want to do a creatine kinase because sometimes myositis, inflammation of the muscle might present like this. Acetylcholine receptor antibody. I've had maybe about 3 patients referred to us for MND, and actually when you investigate them and you look at their features, it was more in keeping with myasthenia gravis, so do consider doing acetylcholine receptor antibodies in this patient. And also multifocal motor neuropathy, especially those presenting with low motor neuron features. So this group of patients, you want to also check for the anti-GM1 antibody. And of course, if there is a family history, and in fact, even if there's no family history, if there are resources to check for mutations in the common genes, then I would do so. Certainly, we picked up about 4 patients that didn't apparently have a history of a family history. So let's go to management, okay? So this is just to give you an idea. I mean, the list is so long of all the drugs that people have tried. And really, you'll recognize riluzole here as the only one. There is another one now of this list that is actually has got some evidence to support. So unfortunately, we still do not have a cure, okay? And we also don't have a drug that stops the disease. So there are 2 drugs that may delay. So there's riluzole. Riluzole improves the survival by a few months. The official study that was done, now 20 odd years ago, that said by about 3 months. But subsequent kind of trials where patients were on riluzole did find that it was, much longer than that, probably about, we're talking about 9 months possibly. And it does improve that time to requiring a breathing support, okay? Edaravone. So this is a free radical. I'll be talking about this as well. So this is something that's approved certainly in Japan, and it's also got FDA approval in the US and South Korea. And also Taiwan, I believe. It doesn't have, interestingly, approval from the European Medical Agency, who really wanted to see more data. We can have it here on a named patient basis. It is an infusion. So riluzole is actually a tablet, whereas edaravone is actually an IV infusion. And it's a cycle of 10 days every month, okay? And it costs about, for us in Malaysia, it costs about $1,200 for the first cycle, and then close to $1,000 subsequent. So both of these in Malaysia are actually very expensive drugs. So riluzole, what is it? It is, so these are some of the trials that's kind of shown the survival for this. So 18 months of use, you would, so you really would need to use it for about 18 months. It did improve survival. And what it does is that it inhibits that glutamate release that causes the hyperexcitability that I was talking about earlier. And edaravone, okay, riluzole again. So further studies did show that it improves survival and time to breathing. So you can use 9% gain in probability of surviving 1 year. So these are some of the data that was gleaned from other studies with regards to riluzole, okay? So this is edaravone, okay? So edaravone is a free radical scavenger, okay? So you get free radicals and that's kind of toxic. Causing kind of oxidative stress. So these are scavengers that actually get rid of this or thought to. So you have to understand, so the data that comes from this is actually showing that patients' functional ability can be delayed by edaravone or slowed by edaravone. But this is in a cohort of patients where the function was actually pretty good to start with. So if you're using the ALS-FRS-R, they have to actually, these were patients that were scoring 3 or more, okay? Not, two, at least 2 or more, but the ones that are better were at least probably the ones that are actually in 3 or more, okay? So these are actually groups of patients that are pretty good to start with. So by the time, so in our cohort, certainly, patients are coming to us at quite a late stage. So they're kind of missing the boat. So it's very difficult to advocate for these very, very expensive drugs when, when probably, the degenerative process has already happened. So you want to try and capture them very early if possible. So what we have concentrated here, because, in Malaysia, unfortunately, our resources are limited, so relying on the drugs, they are not something that is easily approved or well supported from a government side of things. So we focus on trying to do multidisciplinary approach. And this is some of the things that, we hope that everyone out there could also adopt a similar kind of approach where you're involving all the key healthcare workers in caring for the patient and also supporting the caregivers as well. And there is pretty good data to suggest that it does improve, very important, the quality of life of patients, okay? And also to a certain extent, improve the survival. And so that is really, just going back to that. And that is really because, patients in one center, they're able to see everyone and the doctors are also talking to each other. So that kind of approach means that you're doing it, as a team. So it just means that much more for patients as well, I think. Okay, let's talk about non-invasive ventilation. Okay, this is without a doubt. In fact, it's actually much better than the drugs, to be honest. It does definitely improve median survival for sure, and also improve quality of life. So this is the one thing that patients can actually feel the benefit, okay? So yes, officially, they say use it when the vital capacity is less than 50%. If you're able to do the SNP, so that's the nasal inspiratory pressure, you can use it less than 40 centimeters of water, or when you have evidence of nocturnal hypoventilation. For us here, I think, I'm just sharing my experience. Once you start waiting for the vital capacity to be less than 50%, I really think, you're really missing the boat in that it is not an easy kind of intervention for them to get used to. So I do find that once they are symptomatic, that is really one of the, when we're starting to introduce the non-invasive ventilation, using the mask, etc. Because when you start doing that, the acceptability is much better. And also when things get worse later on and when you have to tweak the kind of like pressures, etc., they can tolerate much better. And that has been our experience. So one of the things that we can do here, fortunately, is that we can actually do sleep studies. So once we start seeing that they have abnormalities on sleep studies, and a lot of them actually have obstructive sleep apnea as well. then we will start advocating for the use of NIV. So preventing weight loss, very, very important, okay? When you optimize the nutritional status, you actually do improve survival as well, because we know that rapid weight loss and low BMI is associated with reduced survival. So how do we address that? That is by inserting a gastrostomy tube. And yes, ideally, we do want to do this when the respiratory function is still good. Unfortunately, the acceptance, we do have to take into consideration the social aspect, acceptance of our community here to having PEG. So the majority, if not all of our patients that we do a PEG here is actually those patients with already respiratory impairment. But fortunately, certainly at our center, we've got the support of the anesthetist and also a dedicated anesthetist and gastro team that helps to actually do these patients to minimize the complications. And, just by doing so, you do prolong survival, but more importantly, the patient's quality of life, they're not hungry, they're getting the nutrition so that they're able to breathe, they're able to use whatever function that they do have. So then we get down to symptomatic treatment, and these are really things that directly relate to the actual motor nerve degeneration and those indirectly. So we're talking about all these other indirect features, and these are some of the drugs. You can actually look this up as well. Some of these may not be available here. And finally, to me, I think, palliative is so important, and we certainly here work alongside with the palliative team and the others in our team, and breaking the news is one thing, but also in terms of that psychological support, symptomatic treatment as well, and also the choice whether they want to have any interventions done, advanced care planning, and also to talk to them about what happens, kind of end of life issues. So just to summarize the management, so prompt assessment and diagnosis is what one is targeting for. Try as best as you can wherever you are to try to have this multidisciplinary care approach. Patients do appreciate it. And then you're looking at early treatment with disease-modifying therapy that I mentioned, symptomatic treatment, and for those patients who cannot communicate, start looking at things like eye tracker or simple measures, gastrostomy insertion early if possible, non-invasive ventilation, and advanced care planning, which also include for those patients who also want invasive, tracheostomy, ventilation. And throughout all of this, and I think this is where, I've certainly learned so much from my palliative colleagues about maintaining patient autonomy, their choice, and doing it with the family as well, so that family also understands patient's choice is always important at every step of the way, okay?